So we'll move on to the next session. Jenny Fuda will be the moderator of this session.
Good morning. So I was given the great honor to present the next couple of speakers, and these speakers were selected among all the people who submitted abstract because of the excellence of their abstract. So first of all, I would like to congratulate them for their work. And so our first speaker today is going to be Dr. Andrew McCrary. Okay, so Andrew received his bachelor degree and his medical degree from Emory University, and is currently a fourth-year pediatric resident here at Duke. His main research objective is to differentiate characteristics of poor cardiac function in perinatally HIV-infected children and adolescents using inflammatory and cardiac biomarker as well as their immune status and treatment history. His research is based in Western Kenya at the Moi Teaching and Referral Hospital. Andrew is a recent Year Gantt Center for Global Health, NIH Fogarty Global Health Fellow. And today he will present on the prevalence of early cardiac dysfunction and association with plasma HIV viremia and inflammatory marker in perinatally HIV-infected children and adolescents from Western Kenya. Andrew.
Thank you. Good morning. It's my privilege to present this abstract to everyone today, and specifically because a portion of this study was funded by the Duke CFAR Small Grant Program. Brief agenda, similar to most abstracts. So prior to the era of combination ART, HIV-associated cardiomyopathy was estimated to affect almost a quarter of people living with HIV. If you received that diagnosis, even if the rest of your viral parameters were similar to other individuals without this diagnosis, their life was 75% shorter with just the addition of the cardiac diagnosis. So what is the situation in the era now of widely available combination ART? In general, there's cardiac preservation from structure and function, particularly using traditional measures of echocardiography. In pediatrics, as I'm a pediatric cardiology fellow, this has been evaluated in fetal life, this has been evaluated in infancy, and intermediate to long-term outcomes in children, and it has shown general preservation of cardiac function. But my question is, are we missing some disease? And I say some. And newer technologies from an echo-based platform, such as Strain, which is shown here in the right panel, is been shown to detect disease in other types of acquired heart failure, to detect disease before changes in structure or before changes in ejection fraction. And we also know in HIV-specific, children and adults have abnormalities in strain measurements compared to healthy age-matched controls. Additional information is given to us from cardiac MRI, which can characterize the myocardium itself. And we see that adults, even very well-controlled adults from a viremia standpoint, have higher proportions of myocardial fibrosis and have higher proportions of lipid content within the myocardium. And this is even in the case of good viremia control and normal ejection fraction. The hypothesis is that this fibrosis deposition could be related to chronic unsuppressed inflammation, and that's part of our questions today. So for this abstract, what is the prevalence of early cardiac dysfunction among children and adolescents perinatally HIV-infected in Western Kenya? And is there an association between cardiac function and same-day HIV RNA levels, as well as soluble inflammatory marker levels? This is a cross-sectional study of children and adolescents attending their routine care clinic at Moi Teaching and Referral Hospital through the AMPATH program. And we recruited patients from September of last year to April of this year. General inclusion criteria were that you were attending your adolescent or pediatric HIV clinic and that you were willing to have an echocardiogram and a lab draw. So our data sources for this project include the clinical information that we received at the time that they enrolled in the project, as well as the fairly advanced electronic medical record system that AMPATH employs. Additionally, we have echocardiogram and laboratory data that we'll talk about. Our definition of early cardiac function. On the left-hand side, you see a similar slide with strain. We used, because we were looking at growing children, we used a Z-score calculator. So if the Z-score of strain for that body surface area for that child was less than -2 and the ejection fraction was normal, then we classified that as early cardiac disease, dysfunction. Or another measure that I've not presented to you is myocardial performance index, or MPI, was abnormal with normal ejection fraction. MPI is, in general, a measure of timing, the amount of time that the heart is isovolumic during the cardiac cycle, standardized to the ejection time. This has been, this particular measurement, so with worse, being a higher number, you see 0.5, the cutoff there, a higher number is worse. And this has been shown in other inflammation-based cardiac dysfunction to be more predictive of dysfunction than even strain. So we included that in the definition as well. The analysis, we used appropriate tests for comparisons based on the data, and our multivariable models were built using empiric and hypothesis-driven covariates. So for our data, among the approximately 1,600 children and adolescents that receive care in this clinic that are actively enrolled or engaged, we were able to offer the study to 653 of them. 6 of them declined. 3 were unable to tolerate the echo, and 1 was subsequently found to have undiagnosed significant congenital heart disease and was excluded. We ultimately analyzed for this work 643 children and adolescents. And I have the viral suppression rates because those publicly reported for this clinic were overall similar between participants and those not recruited. Using traditional measures of LV function, like the first slide I showed you in the background, 21 patients had reduced ejection fraction, so would be classified as having cardiac dysfunction, and that's only 3% of the overall population. And only 3 of those had larger ventricular cavity, so they would meet the definition, the study definition of dilated cardiomyopathy or HIV-associated cardiomyopathy, so 3 out of 643. Using our definition of early cardiac dysfunction, strain only detected 2, not 2%, but 2 patients out of the patients that were available after removing the ones with cardiac dysfunction. And myocardial performance index, again, that is a meaningful measure in other inflammation-based cardiac dysfunction, captured, or by the study definition, showed that nearly a quarter, or you see 28% of the children and adolescents met the definition of early cardiac dysfunction. So separating out what was associated with early cardiac dysfunction compared to normal cardiac function, early cardiac dysfunction was associated with older age patient, was associated to a history of AZT exposure, was associated with a higher percentage of detectable HIV RNA levels, and the correlate of a higher mean HIV RNA log level. Looking at inflammation, from the pathways and the hypothesis that I outlined before, we saw that there was an association of a slightly elevated IL-6 level was associated with our definition of early cardiac dysfunction. The 2 markers in the middle are in the pro-inflammatory pathway that leads to fibrosis, and we did not see a significant difference in the 2 groups there. And the last marker is a marker of cardiac dysfunction. We didn't see, and that's usually associated as the heart begins to dilate, and we did not see any significant difference between those 2. Looking at an adjusted model of cardiac function covariates, I'll say that each column represents a different model, and this is of the 285 patients that each model has 285 patients that had detectable HIV RNA levels. We see that ejection fraction is associated with higher HIV RNA levels, and ejection fraction is worse. And let me be clear, ejection fraction is worse with higher same-day HIV RNA levels, and worse with history of AZT exposure. But interestingly, there's a protective effect that the higher the proportion of your life that you've been on ART, improved cardiac function. And these, to my knowledge, are all new data to this field. Looking at the other measures of continuous cardiac function, strain and MPI, we did not see that they correlated with these measures of these HIV history components. And we're still working out and going through the rest of the models. And this is a slightly different population than what I just showed you in the bivariate analysis. So conclusions. Nearly 1/4 of the study participants demonstrated evidence of early cardiac dysfunction. Early cardiac dysfunction was associated with elevated HIV RNA levels and a generalized inflammatory marker, IL-6. In adjusted modeling, detectable and increasing same-day HIV RNA level and AZT exposure were associated with worse ejection fraction. First, I'd like to say acknowledge the children and adolescents that participated in this study in Western Kenya, and particularly their care providers, and from our study team in Kenya, Elsie Bergen, and particularly the work over the last couple months with Alicia Ellis from the Duke CFAR Statistical Core, and mentors Dr. Bloomfield and Thielman. Thank you.
Questions for Andrew?
The association with AZT exposure, was that expected, unexpected?
We, as you know, in the literature, there's been a lot that's been described with AZT associated with myocardial dysfunction, and particularly the thickening of the ventricular wall. That has been seen as you remove AZT from them, the size of the ventricle goes back to normal, which we saw the size being normal in our study as well, but we found that there was an impact on function even years after AZT exposure. Unfortunately, the data we have is not robust enough for us to quantify the amount of exposure that they received, but just a yes, no, if they've ever received it as a part of their treatment regimen. And in Kenya, when ART was widely available, starting in 2004, in general going forward, none of these children were ever exposed to single AZT or high-dose AZT. Yes, Lance.
Marker of historical immunosuppression. You guys obviously don't have archived viral loads there, so that's not really an option. But did you look at historical CD4s? Because that should be available.
Interesting that we've tried. That's a challenge. So the system itself, we have to rely on what's clinically available for historical purposes. And they only provided CD4 absolute numbers, and in children, the CD4-CD8 ratio is more valuable, but that wasn't reported historically. Additionally, so naders weren't frequently available on even our older patients that are available. We do have about 3 years of data of HIV RNA levels, since that's become the clinical practice, and CD4 level checks are no longer routinely done in these clinics. So we may be able to do a subgroup analysis, kind of particularly of individuals that have started ART within the last 3 years, to see the impact of unsuppressed viral replication and their impact of viral suppression. But those data are not as great.
So, and what are your plans? So now that you identify, how is it going to improve the
care for these children?
Yeah.
We need, and still working with the core here, we're continuing to finish the modeling and fully understanding the implication of the inflammatory markers as outcomes, and developing models to make sure we understand all the covariates there. This may be well known to the group. IL-6 has been heavily studied in HIV literature. It's also heavily studied in cardiovascular literature separate, and was part of the initial indication for starting low-dose aspirin in adults, was elevated levels of IL-6. Again, there's a number of things to kind of unpack and understand. The short term is to finish the analysis. The kind of intermediate step is we have some additional funding to look at EBV and CMV quantitative levels, wholesale quantitative levels from the same day, to see if there's any impact of concurrent coviremia. And then the next step is that this group needs to be followed up. This is a cross-sectional study, and we need to see what the clinical impact of this early cardiac dysfunction ultimately is. These are new data. In general, the vast majority of the papers out there would say there's no dysfunction in these children, so we will have to rigorously defend that.
Thank you.
Sure, thank you.